There we go. We're going to go ahead and we're going to get started, guys. So if I can ask the speakers to come up and have a seat over here. And Ed, if you can turn on your camera so that we can involve you with the Q&A, that'd be great. And David, if we could have you come up to the stage. Super. All right, so appreciate everyone hanging in. We had a lot of amazing presentations today and really remarkable depth and breadth of various topics that sort of all came together in some way. I'm always amazed at sort of that natural synergy. And first question I have for all of you, what are your thoughts on therapist job security due to the increasing number of people turning to AI technologies for therapy?
Here we go. Just because coming off the presentation, I think if we do go that route, we stand to lose the most important part of therapy, which is understanding how to get along with other humans. And also the most enriching part about being alive. I'm sure many of you are familiar with the Harvard study of adult development, which basically says those of us that are the happiest and feel the healthiest are those with the best relationships. And if we can't get that modeled with you all, I think we're in trouble. So all I'll say is I hope that does not happen, and we need to protect it.
Not going to happen, I don't think. I think AI could be a reminder system, hey, I see you didn't sleep well in the last 3 days. Maybe you should do something today that might be restful. Let's plan that out. But that's where I think it's going now.
Yeah, it's interesting. So I was involved in the chair searches for radiology and now pathology. And in their departments, for instance, AI is critically important and is going to be playing an ever-increasing role. So I think if anything, right, the radiologists and pathologists probably have to be a little bit nervous in terms of it. I mean, it's framed now as improving access and, there's a workforce shortage, so why don't we try and prioritize things? But I think, as you start looking at a chest x-ray, how much of that could be, learned by a computer and sort of focus on those things. So it'll be sort of an interesting development in the future. All right, the next question I have, and I think we're going to have someone around with a microphone there, so if there are folks in the audience who want to ask questions as well. But I will, the second question we had online was, how are providers treating patients in the residual stages of schizophrenia? Is the focus on positive symptoms or more on cognitive negative symptoms? And how do you make that a priority? So Rob, maybe you can take first stab at that.
Yeah, so residual phase of schizophrenia is usually in people's 40s, 50s and on when they've had maybe multiple episodes, generally are doing kind of more stable with maybe a persistent lower level of symptomatology. I think it depends on the patient. In generally the medications are the same choices, so using what's most effective, change if you need to. And then kind of at the end of the talk, I mentioned some kind of non-medication interventions. So if there's certain types of therapy, we didn't really talk about it, but there are some social skills training specifically or cognitive rehabilitation interventions that can particularly help patients with specific deficits that you notice. The challenge is it's very clinician driven and a very clinical decision rather than it's algorithmic, I guess.
All right, just checking to make sure there were no other questions in the chat. Questions here in the audience as we interrupt your lunch. Jill, hang on one second.
No, just thinking about what you said, Rob, about, the incidence, of marijuana, how it affects schizophrenia, and we have so many patients that, live in their parents' basement and vape all day long. And it just, I don't know, the society just seems to make marijuana so benign, like this idea. And, it would be nice to see if there was, a more of a push to get that out there.
Yeah, I'm sorry. Go ahead, bro. No, I was just going to say, I mean, it's interesting, right? This whole discussion around legalization of marijuana, and particularly as folks have tried to frame it as a medical marijuana, right? I always remind people it's medicinal, not medical, because all of the professional medical organizations are against the legalization of marijuana. There's not one that's in favor of it, right? In part because we can't predict who is going to be vulnerable, right? So I always think back to, as I date myself, the past times at Ridgemont High, right? And think of that subset of people who just are not productive, not able to move out of their parents' basement and do all those things. And looking at a kid, I don't have any idea of who can smoke marijuana fine and, who can't. And so with that, it's such a high risk, sort of low reward sort of scenario. You sort of wonder why it ever made it. And I guess the answer, and I'm sure at least David would probably agree with me, right? It's money that drives that, right? In the same way, why are cigarettes legal and alcohol legal, right? Because without it, the state of Kentucky would disappear and, Milwaukee would, and St. Louis would disappear, right? So, these are just, economic decisions sometimes that are not driven by clinical decisions. So, Rob, I don't know, anything else you'd like to add?
Yeah, it's a big challenge because before it was legal, you could just say it's illegal, so you shouldn't be using it. And that was an easy out for us as clinicians. Now that it's legal, I guess my tact on it is, yes, it's legal, but it's not a good substance for you. Like whatever it just doesn't work with your body. It doesn't go well with your body. Every time you've used, you end up in the hospital, and use kind of that motivational interviewing strategy to kind of help raise up the level of consequences to their awareness enough so that they'll be motivated to make a change or cut back or whatever they can do to reduce that risk. Yep.
Super. So Ed, I appreciate you being back on mic, and you were started us off this morning. So I'm wondering if maybe after listening to any of the speakers, there were any questions that you had that we could take advantage of. No pressure if not. Hang on a second, Ed. We lost the sound here in the auditorium.
Sorry.
Oh, there you go. Yep, that's perfect. Yep.
Sorry. Yeah, no, I really learned a lot, appreciated hearing all the speakers, but I wasn't prepared to ask questions as opposed to answer.
No worries. Didn't mean to put you on the spot. Just wanted to give you the opportunity.
Flexibility on my part.
No worries. Thank you. Other questions? Yep, we got a question over here. Hold on one second.
I'd like this to be a question for all of you. It kind of stems from some of the terms I've been hearing surrounding patient care, like average consumer, social context, alliance, and even comorbidities. In either of your research or your development, what are your considerations with like differences that come to race, ethnicity, and culture? Because I would imagine that those affect everything from genetics to direct patient care to looking at like your consumer market.
I can speak quickly to the genetics if that's okay.
Sure, please. Thanks.
One issue in the genetic studies is they've been largely or predominantly of European origin. And one thing we didn't talk about is the development in medicine of polygenic risk scores, where you take all these thousands of variants and come up with saying someone's at higher or lower risk, let's say for schizophrenia, where it works the best. And those are there are two problems. One is the data to drive that is almost all European and not generalizable. And the second part is, as you know, we look around and this is a good thing. people don't come from one of the three main populations, much less subpopulations of Asia, Africa, and Europe, Western Europe. So when we start to do those studies of polygenic scores, we'll often lose a lot of data because, parents may not be of just one population origin versus both. So that's actually a big challenge for the future, both to include more diversity in those samples as well as to develop models that can address the complexity and diversity that we live with and are glad to embrace.
Thanks, Ed. Jubal?
I think Dr. Cook. What Dr. Cook talked about is polygenic risk score, like from genetic perspective. From the the biology side, actually, when we try to use iPSC to model the disease risk factors, we also face the question, what kind of donor, like genetic background, we want to use. Like, you only use one cell line or different cell line from different ethogenic background, or male or females. Those questions. For some highly penetrant genetic risk variant, for example, what we found, for example, the SETD1A gene I mentioned, we studied quite a few genetic background. We found, if you look at the biological effect, actually they're pretty similar actually for those highly penetrant genetic risk factors. But for common GWAS risk variant, we knew it's kind of population specific. There are a lot of loci. They are specific to different populations. Despite different population specific common risk variant, if they point to the same gene, you would also expect the same biological effect from the specific genes, right? So I think there are different ways to look at this issue, from biological perspective in the context of genetic association thing.
All right. So I had a question pop up in the chat here from Dr. Noel. So I hope I'm getting this correctly. She was asking about the family of a patient on Clozaril, who was asking about the Lateman protocol and the Team Daniel protocol. I've not heard of either of those, so. Okay. Anyone in the audience? Yeah, so Amy, no one's aware of those. We'll try and get some more information and get back to you. Other questions? Oh, yep.
I am not a clinician, so I want to thank you all for what you do, and because I'm an outside person that has experience with family, I guess, having some of the issues. So I wanted to do that. I also wanted to say regarding the AI, I raised kids when the internet was starting to come out, and the instant messenger started. I had a son in middle school, and another mom said to me, "Isn't it great? They can just type on the computer and they don't have to face each other." I'm like, "Do you hear yourself?" No, this is not a good thing. We need family, or we need people contact and stuff. So that's just a sidebar. My question is, have you found any methodology or suggestions when you have people that you care about that don't think they need help, or don't like the medical community, or don't think anything's wrong with them? How can you start to convince them? I don't know if with any of your experience, if you have any ideas.
Yeah, that's a really difficult situation. Yeah, I think there are maybe some different approaches. I don't know if there's a tried and true approach. I think if there is someone that person does trust and can be a liaison between the medical community or clinician and themselves, like a family member that they do trust the opinion of, or they do trust having kind of like an intervention, like, okay, let's all sit down and talk together type of thing. I mean, that I've had some success with that. Or I guess kind of ramping up the external controls depending on the risk and severity, like family needs to set these boundaries now, and if you can't agree to continue doing treatment or continue taking medication, you can't stay with us anymore. I'm sorry. Like having to set some like tough love limits on things. Ultimately, there's a legal pathway. If someone is significantly impaired and they really need medical care, to go in front of a judge and have a judge make a determination that this person needs either inpatient care or like an outpatient medication order.
Yeah, and I'll just piggyback on that. I was looking around the room. I thought Dr. Goldenberg might be in the room. I hope he's listening online. One of the issues we've been struggling with a patient at Swedish recently is the conflicting ethical dilemmas of autonomy and paternalism, right? And how do we find the right balance in that to allow someone self-determination, making decisions, even if they are the bad decisions or decisions we might not agree with or make ourselves? Where does that line get crossed? Until then, it's an issue around safety and risk, right? And that is a gray zone that does not have clear parameters that direct us. So it's a little bit of that feel of, wow, this feels like we're now getting into a situation where I need to maybe involve the legal guidance and other things, because that is a constant dilemma that we face in psychiatry particularly.
I'd like to add something to the question of the book "I'm Not Sick, I Don't Need Help" by Javier Amador. I'd strongly recommend. It's helpful to families, has a lot of really good ideas about, I think the basic concept that we all use is what is important to the person. I think Dr. Marvin was alluding to that. What are your goals, without having to speak to diagnosis that may, as he mentioned, particularly early in the course or dependent even longer in the course, without insight, to talk about what do they want for themselves, and how, for example, medication adherence might help with that.
Yeah, thanks, Ed. As a child psychiatrist, I certainly use that aspect of motivational interviewing, right? Which is, okay, getting treatment for this disorder is not at the top of your list, but getting your parents off your back is your most important concern. How do we get your parents off your back? It's maybe to go to your appointments or take this medicine or whatever else, right? So trying to use that as the way to spin that engagement. So that's certainly an important part of it.
So my question, which piggybacks on what he just referred to, the literature, is how many of the people that are clinicians are aware of that work and are using what is called the LEAP method? Is that something that you train everybody at Endeavor with, or?
So not that specific technique, but I think principles of that technique are generally things that are common in most multidisciplinary training programs. So whether you're talking about medical schools, social work schools, psychology, that have certainly some aspects of that we bring in. And I think the book that Dr. Cook is referencing synthesizes that and frames it a little bit more for families rather than for clinicians. But there are absolutely lots of those skills that are critically important and part of our training.
I'll also put a plug in for the mental health care directive that the state of Illinois has. So in Illinois, we can basically put together an advanced directive for mental health care. So it's a document that anybody can fill out, and it's like an advanced directive saying, if I should become ill or incapacitated, this is what I want to have happen and not happen to me. And it's all focused around behavioral health and mental health. So it's medications I want or not want, ECT, yes or no. If I become hospitalized and I need decisional support, this is the person that can make these decisions for me. And then if the patient does get hospitalized and they're deemed to be unable to make decisions for themselves, this document kicks in and all those predetermined decisions can be effective and really help them guide care. And it can be really a useful adjunct to care for patients who, when they're feeling well, are insightful and have good decision making, and they have their best goals in mind. But when they become sick, they kind of lose those capacities and end up and then in my experience, it's the patient who has a manic episode and then 3 months later they realize, wow, look at all this stuff I've done. If I had just gotten started on this medication I know works for me 3 months ago, I would have been better. So it can really help in those situations where they know what works for them.
We had a question come online asking about if folks could expand on biggest concerns about uncertainty in government. So I'll look right at you, David, as I ask that question. You're among friends.
It's so hard. It's so hard to know because there doesn't seem to be a set of guiding principles. So how, you know, again, I feel like I can't speak my ultimate truth on this, but yes. So
We're all gonna think the same thing.
I just think that there's,
Yeah, so maybe I'll start and then see if there's something you want to jump in there, because I think that point about uncertainty is certainly a huge part, right? There's a certain amount of predictability that goes on as administration changes, right? There's some Democratic Party principles, there's some Republican Party principles, and so you get some sense if, you know, the ground shifts one way or the other way. You know, we're going to be within the rules. We'll lean a little left, lean a little right, but we've got some predictability about that. So I think it seems like we've lost a lot of that predictability. So that's certainly one major uncertainty. I think the other piece of it is that it seems that you've got individuals making decisions based on their own personal life experiences as opposed to the evidence-based. So I saw that in one of your first slides, right, was about evidence-based being critical for some of the components. And without that evidence base, and it's just like, oh, Ramon, I decide I like, you know, sunny days rather than rainy days, and all of a sudden we're out in left field.
the thing is, I'm trying to be sort of fair and impartial, which maybe is impossible. Look, you guys know the geography I live in, and you can guess at my politics. But I also want to say that when it comes to things like junk food, right? Like that might be a good thing that comes out of this. It might be coming from a person who is not of sound state and for reasons that we don't understand, but there might be some strange benefits that happen. I'm not banking on too many of them, but I will say that things that I think are relatively safe are Medicare. I think if you touch Medicare, it's a third rail, and my hope would be that nobody goes there. And if that happens, maybe the next election will be different. And when it comes to investing in novel drugs, I mean, and things like the DEA, I don't know. It's very hard for me to make sense of it.
Yeah, no, I think that unpredictability is certainly the biggest part.
And one concern I have is on the regulatory standpoint. I think one of the efforts is to decrease regulatory burden. And my concern about that, I guess, without evidence, I guess, is the risk for safety and safety events. If there's less regulatory burden, or less reporting required around certain things, that's going to open us up to more risk. We'll have to see on that one.
Fair enough. All right, and I think I saw the last question pop up there from Rena, which is for you, Ed, about the interface of OCD and spectrum, someone who gets stuck on almost every word and not in perfect alignment with obsessions. So wondering if you can think through that a little bit and feel comfortable replying.
Tough situation. Should I say what the question was?
If you can synthesize the question, I'd appreciate it.
Yeah, interface of OCD, also likely spectrum, which I assume is autism spectrum. Adult refusing treatment, gets stuck on almost every word, not in perfect alignment with obsessions. Believes irrational fear is true. Then goes down a rabbit hole with yet another word. Not available for reciprocal conversation. The only human connection is with family, so family maintains ties in a logical dialogue for reassurance. Difficult case. I could have given a talk or the whole morning on difficult cases.
That's for next year, Ed.
Yeah. One of the disadvantages of decades of treatment is talking to the parent about how you haven't really gotten that far in all this time. But I mean, from what I'm hearing, trying to treat the OCD, which I assume, knowing how skilled Dr. Goodfriend-Levy is being done well. Hopefully able to get the family and the patient to comply with that. A lot of ideas about how to work on refractory OCD. And then the other thing that's alluded to here in OCD treatment especially is, of course, you want to do exposure with response prevention, but when the anxiety is so high and the internal motivation isn't high enough, it's hard to actually get past the just wanting to reduce the anxiety acutely, which is going to increase the anxiety and the connection between anxiety and compulsions over time. In families, it's hard. I wouldn't say that I would be good at this myself, but it's hard to work with the families not to, as Dr. Goodfriend-Levy mentions, sort of give in and reassure, which is sort of a natural reaction, which I think is some of the paradox of OCD behavioral treatment, that you're having to do what wouldn't come naturally to try to reduce anxiety.
Super, thanks. Let the microphone come to you there. And Zahava, we'll make this the last question here in the audience.
So I never really knew about the relationship between autistic spectrum disorders and psychotic disorders. So it sounds as though there's some genetic overlap. I wasn't clear on that. So anything you could say to elucidate would be helpful.
Yeah, I can say something because I was like, oh, why am I invited to this? I think it's because we're using similar tools. I did show, and Dr. Dwan showed overlaps in some of the rare findings. So, for example, if you have the 22q deletion, it's interesting. It often presents as autism or ADHD early, and then psychosis happens later, and consistent with the usual psychosis onset that Dr. Marvin said. In general, and that's the problem, saying in general, there's not an increased risk of psychosis in autism, and if there is, it's probably more mood-related psychosis. But I think the point is, in getting to these more specific causes, like the 22q11 deletion, or like Norexin deletions, or the 16p11 duplications, it's not the overall 1% with schizophrenia and about 1% with autism and lumping everyone together, but trying to get much more specific diagnoses where if we did identify the 22q11 deletion as somebody presenting young with autism or ADHD, we would see them at high risk for psychosis.
Thank you.
Super. So appreciate everyone's engagement. I'm just going to see if anyone on the panel has any last thoughts before we wrap up. Lots of head shaking? No? All right. Well, thank you all. Yep. Have a great day and stay tuned for next year. Thanks, Ed.
Thank you.
Thanks, everyone.